Thank you, sir. Again, a very warm morning to everybody. I'll be running very fast with the topic of traumatic optic neuropathy and traumatic glaucoma. Well, a little bit about the epidemiology of the traumatic optic neuropathy. It occurs in 0.5 to 5% of the patients presenting with closed globe head trauma and 2.5% of the patients presenting with midfacial fracture, more commoner in the younger patients and males. If we look upon the etiology of the trauma, it depends upon the age. While in adults, the commoner cause is the road traffic accident, fall, assault, while in children, it's most commonly by the fall or a motor vehicle accident. Again, we classify traumatic optic neuropathy based on three principles. The traditional classification is direct and indirect. Based on the site of injury, it can be orbital, intracananular, or intracranial, or based upon the fundus features, it can be an optic disc trauma or avulsion. It can be an anterior optic neuropathy or a posterior optic neuropathy. Well, something about the direct injury. Well, the direct injuries are not that commoner as indirect injuries. It results from an object that penetrates the orbit and impinge upon the optic nerve, causing optic neuropathy by partial or a complete transection of the optic nerve sheath. Hemorrhages within and around the nerve may be seen. This leads to an immediate change in the optic nerve, and we see it in fundus, which can be detected by the ophthalmoscopic examination. As you can see in this case, there is a lot of hemorrhage around the optic nerve. This is how the optic nerve will appear with a direct transection, and this is radiographic representation of the same. The things has gone from this side. So indirect injury. This is a more commoner form of the optic neuropathy. Indirect optic neuropathy is caused by the transmission of the forces to the optic nerve from a distant site without disruption of the normal tissue structures. The deformative stress is transmitted to the skull from a blunt trauma is concentrated in the region of optic canal, and the most common site being the temporal part of the brow, because it is mostly exposed. So indirect injury also we can have two classes. One is the anterior and the posterior. The landmark being a point where the central retinal artery enters and the central retinal vein exits. That is 8 to 12 millimeter posterior to the insertion of the optic nerve into the globe. And any injury which is anterior to this point is called an anterior traumatic optic neuropathy, and anything posterior to it is called as a posterior traumatic optic neuropathy. A little bit about the pathogenesis of the disease. The primary mechanism is the shearing injury, localized ischemia and the optic nerve edema, which further causes ischemia and because of the compartment syndrome, and then this leads to the permanent damage. The secondary mechanism put forth by various authors are like ischemia and the reperfusion injury, the bradykinins, the calcium ion channels, and the cell-mediated mechanisms. Well, about the clinical features, the traumatic optic neuropathy is a clinical diagnosis which is made when there is an evidence of optic neuropathy followed by a history of blunt or a penetrating trauma. Very, very important point is pupillary evaluation. It's said that the relative afferent pupillary defect is a sine qua non for a case of unilateral traumatic optic neuropathy. In the absence of iropathy, either there is no traumatic optic neuropathy or sometimes it can be a bilateral traumatic optic neuropathy. So the most important clinical feature or clinical finding you will get in any case of a trauma at times is only RAPD and a vague history of trauma. Well, the various investigations are the neuroimaging, VEP or ERG. About the management. Essentially, this is a multidisciplinary approach involving the ophthalmologist, physician, neurosurgeon, and the otorhinolaryngologist. The optimum management protocol is yet to be elucidated because of the paucity of prospective large clinical trials, but the various approaches which are with us are the observation, steroid, or a surgery. Well, the use of the high-dose corticosteroid of the optic nerve injury began in 1980s following a report from the Anderson et al. And the vast majority of us basically base our steroid treatment on this landmark study called as a National Acute Spinal Cord Injury 2, that is NACIS 2. It was a multi-center clinical trial that evaluated patients with an acute spinal cord injury, and we extrapolated their result in traumatic optic neuropathy. It showed that methylprednisolone in the loading dose of 30 mg per kg body weight followed by 5.4 mg per kg per hour for next 24 hours started within 8 hours of the injury and associated with significant improvement in both motor and sensory functions compared to the patient treated with the placebo. The study was done in spinal cord injury, but we extrapolated it to the traumatic optic neuropathy and applied the same principle as I elucidated. Well, the surgery, the Ficado et al. In the largest series of 400 cases had suggested a good results in optic canal decompression surgery. Various surgical approaches for the decompression of the optic canal includes the transfrontal craniotomy, the extranasal transethmoidal, the transnasal transethmoidal, lateral facial, sublabial, and nowadays even endoscopic approaches are there. So to summarize the treatment, the optic nerve laceration, no effective treatment; optic nerve devaluation, no effective treatment; optic nerve sheath hematoma, the treatment will depend upon the surgeon's efficacy. Optic nerve sheath administration may be helpful in acute stage if the optic neuropathy is progressing or there is no other cause evident. The most common we generally encounter is a decelerating injury. The effective treatment for the posterior, most commonly the posterior indirect traumatic optic neuropathy is at the best extremely limited. In vast majority of the cases, observation alone is recommended but high dose corticosteroid therapy, most of the people and most of the time we use, but it has to be used with caution. It should never be offered by an ophthalmologist to the patients with a concomitant traumatic brain injury, or if the traumatic optic neuropathy is older than 8 hours. So my submission would be, if at all you want to use oral steroid therapy, say after 8 hours, you can just go for a oral steroid. The prognosis will depend upon the presence of blood within the posterior ethmoidal cell. The age more than 40 years will have a poorer prognosis. Loss of consciousness associated with the traumatic optic neuropathy and an absence of recovery after 48 hours of the steroid therapy are the poor prognostic factors in traumatic optic neuropathy. This completes the traumatic optic neuropathy. We again come to another very important aspect of the trauma, that is basically traumatic glaucoma. Well, something about the definition of traumatic glaucoma. The fundamental structural and measures typically used to define glaucoma are often not reliable in a traumatized eye. So, the old principle of eye pressure, visual field, and the optic nerve, you cannot apply it in the case of trauma. So, we do not specifically define traumatic glaucoma using visual field and optic nerve head, but largely rely on persistently elevated IOP as a marker of traumatic glaucoma. And by this, many of glaucomologists use the terminologies as traumatic ocular hypertension rather than a traumatic glaucoma. So epidemiology, the overall incidence of glaucoma after ocular contusion ranges from say about 2% to the 43%. The closed globe injury shares 68 to 77%, whereas an open globe injury has a share of 23 to 32%. If we broadly classify a traumatic glaucoma, will have either because of the blunt injury or because of the penetrating injury. In a blunt injury, the rise in pressure could be an early onset or it can be a delayed. The early onset, the commoner cause being the iritis, which is very commonly we see in any of our blunt trauma injury, or a hyphema. In a delayed onset, again angle recession glaucoma is a very important, because angle recession glaucoma has become synonymous with the post-traumatic glaucoma. And, penetrating injury are less common a cause of a traumatic glaucoma, but then there are certain mechanisms like epithelial or stromal down growth will cause clogging of the trabecular meshwork, and finally angle closure glaucoma. And if you have a intraocular foreign body, something like iron, you can have a siderosis, and siderosis can cause both raised in IOP and at times it can even cause an hypotony. So other situations wherein you can have a traumatic optic neuropathy are something like chemical injury, the ocular surgeries, just to classify it. So before going into details of the forms of the injury, we should all, especially the resident, should remember the 7 rings of injury of the blunt trauma. Whenever there is a blunt trauma, the eye is basically have 7 places at which it is little weaker. So it gives away at those points. The points are this pupillary tear, which basically causes sphincter tear, can have an iridodialysis. You can have an angle recession, that is a tear in the ciliary body. You can have a cyclodialysis.
Dr. Randhir, be a little brief.
Okay, I'll skip this slide and we'll move on to the specific causes. The traumatic iritis, the IOP tend to rise in a few days after injury, and the recommended treatment is just cycloplegic and topical steroid. If the pressure is high, you can use the hypotensive agents. Prostaglandin analog and pilocarpines are to be avoided. The hyphema, there is a lot of controversies in the management of the hyphema, but the most accepted things I will be presenting is hyphema patient need to be followed daily for 3 to 5 days to monitor for the rebleed and IOP checks. Advise eye rest, but there's a controversy about the hospitalization. Most of the Western literature favors hospitalizing a patient with the hyphema, but in Indian scenario we don't have such protocol as such. Pressure over 25 should always be treated mostly medically, and a surgical washout of the anterior chamber is reserved for cases with elevated IOP uncontrolled by medical therapy or if there is an evidence of corneal blood staining. Now we come to the most common and the most widely discussed term is angulation. Any patient with the blunt trauma need careful gonioscopic examination of the angle of both eye to look for an evidence of an angle recession. It represents a viable marker of invisible damage sustained by the trabecular meshwork because angle recession in itself is not a cause of glaucoma. So this is how you can see a broad ciliary body band in this case. So what is angle recession? It is just a cleavage between the circular and the longitudinal fibers of the ciliary muscle with secondary damage to the trabecular meshwork, and it appears as a wide open angle as compared to the other eye. Therefore, the other eye gonioscopy is very important. 60% of the hyphema have some form of angulation, and 6% of them will go on to develop glaucoma afterwards. And any angulation which is more than 60 degrees has more higher risk of likelihood of raising IOP. The management of angle recession glaucoma is just like any open angle glaucoma. Something about the ghost cell glaucoma, because the red blood cells, fresh red blood cells are pliable and they can percolate through the trabecular meshwork, whereas the degenerated ghost cell erythrocytes are rigid and they cannot cause a rise in IOP by obstructing the trabecular meshwork. It's a relatively transient and medical treatment is sufficient for this. At times you might require anterior chamber washout or sometimes vitrectomy also. So this completes with the traumatic optic neuropathy and traumatic glaucoma. Thank you very much.